مرحبا يعطيكم العافية. اليوم راح نحكي عن ال orthodontic and orthognathic surgery. Um, so now, as you know, for orthodontic patients, we have four treatment options. Either accept, graft modification, camouflage treatment, and the last one is orthognathic surgery. And I'm sure we have so far discussed three previous options, and now the last one is orthognathic surgery. So this is going to be our topic for today. So what we'll do exactly with orthognathic surgery. The patient will have, for example, retruded chin, so we prepare the patient orthodontically, and then the surgeon will do the surgery in which, so as you can see, we prepare the patient orthodontically, then the surgeon, for example, here he did what we call it BSSO surgery, bisagittal split osteotomy, so they slide the mandible forward, for example, in this patient, and this is going to result in improvement of the profile of the patient. So as we mentioned before, the only way to improve the patient profile in a huge amount like this is to do an orthognathic surgery. So what are we going to discuss today? First, we're going to talk about the indications of the combined orthodontic and orthognathic surgery, when to do that. Then understand the process of diagnosis and treatment planning. Then to be familiar with what we do in a pre-surgical orthodontics, and then what we do for post-surgical orthodontics. And the last one is to recognize the development of the new 3D technology. So the indications, when to do for orthognathic surgery. Generally speaking, orthognathic surgery is aimed to correct dentofacial deformity. So what do we mean by dentofacial deformity? It's a deviation from normal facial proportions and dental relationships that is severe enough to be handicapping to the patient. And usually what handicap patient, it will be in two possible ways, either jaw function or anesthetics. So for example, this patient here is complaining about the aesthetics. She doesn't like the appearance of her face and her teeth. So in this case here, nothing can help the patient but orthognathic surgery. The other option is this patient. He is very happy with the way he looks. However, he's not happy with the function. He can't bite the food. So if you want to eat a sandwich, he has to cut it in pieces with his hand. So in these patients, usually he's not complaining about the aesthetic, but he's complaining about the function. Or the patient can complain of both if he doesn't like the look of his teeth as this patient, and at the same time the teeth doesn't work properly, and he needs orthognathic surgery to improve the function of speaking and eating. So we get these two examples of aesthetic and function, or aesthetic and function, to be indicated for orthognathic surgery. So, as the objective of any orthodontic treatment, at the end we have to have an acceptable dental and facial aesthetic, good function, optimal oral health, and stability of the results. These two patients will be discussed in detail during the whole lecture. One of them has a class 2, one of them has a class 3. So, how we do this? We start with the examination, we start with the history. So, when a patient attends the clinic, we need to know exactly what are the patient's concerns. So, if the patient is complaining about his teeth, now then we can look at the different orthodontic options, if we can do it or not orthodontically. But if the patient is concerned about his appearance, then no orthodontic option alone can help the patient, and he definitely has to go for orthognathic surgery, even if we can correct his malocclusion by orthodontic treatment alone. However, we need to be sure about the patient's motivation, expectation, and psychological status. How is that? For example, if the patient wants to do an orthognathic surgery because he can't get a job، معناته أنا هذا المريض إذا هو بده يركن كل شيء وكل حياته على إنه يصلح بس شكله، وبالتالي إنه هو راح ياخد شغل، أكيد لا. So the motivation should be very obvious and the expectation as well. So احنا لما بيجي مريض عندنا اوكي احنا راح نعمل لك orthognathic surgery, we're gonna improve your profile، بس مش معناته انه انا راح احل كل مشاكلك، اضبط انفك، اضبط عينيك، this is not gonna happen with orthognathic surgery. So we need to know exactly what is the patient expected, and again the psychological status of the patient is very important. How is that? We have something we call it body dysmorphic disorder. These patients usually present with a non-existent or very minor facial deformity, and they are very obsession with this image. So they exaggerate this defect of the appearance. So basically, what they do think, so they have a very minor jaw discrepancy or teeth discrepancy, but they see it as a huge defect that it needs to be fixed. Now, these people are very dangerous because no matter what you can do for them, they will not be happy or satisfied. So it's important to be part of a psychologist to be part of the team for the assessment of the patients who's going to go for orthodontic surgery to make sure that they will not have body dysmorphic disorder. For example, this patient, she doesn't have a body dysmorphic disorder, but just an example, she's pretty girl, but she's complaining about the look of her teeth and slightly of her chin. So what we did for her was not an orthognathic surgery, it was an only orthodontic treatment. We convinced her that she looked good enough not to go for orthodontic surgery, and she was happy. Now, this patient, if she was a body dysmorphic disorder and we operated on her and we did an orthodontic surgery, we will end up with a lot of trouble because she will not be happy. For sure, you have to check the medical and dental history for the patient. I'm not going to go through details of that one. Now, what about the clinical examination? Clinical examination, you have to do a full face assessment, profile assessment, smile aesthetic, TMJ, and then intraoral assessment. So about the, sorry again, it's a full face assessment, profile assessment, smile aesthetics, TMJ, and intraoral assessment. So what it's going to do in the full face assessment? We use the face rule of fifth to examine the proportion of the face. So we started by outer side of the ear to the outer canthus, then inner canthus, and the same we do on the other side. We make sure that all these parts are equal. And then we drop the mid-sagittal plane to make sure that the chin is sitting in the middle of this line. And as you can see here in this patient on the right side, the chin is slightly deviated to the right, which means that the patient has asymmetry. While in the patient, the young man here on the left side, he doesn't have any asymmetry. They look pretty much symmetrical. We have, again, for the full face assessment, we have to look at the lower facial third. So we have to make sure that each thirds are equal. So if you can see on the left side, again, the lower third is the face is increased, while here on the right side, on the left side, the patient has a reduced lower facial height. We have to check as well the canting in the occlusal plane. So basically we draw a line that is interpapillary line, and we make sure that the occlusal plane of the inside of the teeth is parallel to this interpapillary line, and that there is no canting in the occlusion to the right or to the left. As we can see in this patient, we can ask her to bite on a tongue depressor, and we can compare that to the papillary line, because that's going to affect the surgical movement that we're going to do. And you can see here that there is a maxillary canting, or there is a cant in the occlusion, and the occlusal plane is tipped downward on the right side. So now we assess the patient from full face. Now we're going to do profile assessment. It's very important, as we said, that the patient will be sitting on the natural head position, not tilting the head downward or upwards, because this is going to affect the surgical movement that we're going to do. So if you can see here that the patient has a class 2 skeletal, and now we want to know what is the etiology for this class 2 skeletal. So we use what we call it the zero meridian line, which is a line that we drop perpendicular from nasien to the Frankfurt plane. The chin should be sitting on this line. So if the chin is sitting posterior to this line, that means that we have a retrographic mandible, sorry. So if you look at this patient here, you can see that we have a retrographic mandible. However, it's opposite to the patient with class 3. We use the zero meridian line, and it's telling us that the patient has prognathic mandible. We also have to look at the features of the maxilla. If the patient has a paranasal hollowing, as we can see in this patient, there is no infraorbital rim, there is no nasolabial fold, and there is no zygoma on the patient on the right side. So that means that the patient has what we call it a retrographic maxilla. So, however, in the man on the left side, it looks that the maxilla is slightly posterior as well. We don't have a strong cheekbones or a nasolabial fold. So now we know for a fact that the girl patient on the right side, has a prognathic mandible. She has a class 3 retrognathic maxilla, and the guy on the left side, he has a class 2 due to retrognathic mandible mainly, maybe slight weakness of the maxilla, not as the patient on the right side. Okay. We also have to assess the nasolabial angle to make sure about the tooth movement that we're going to do. For example, the guy here has an increased nasolabial angle and the girl as well. That means that we want to move the maxilla forward or to move the teeth forward in order to improve this nasolabial angle. We have to check the growth rotation. So the patient on the left has a posterior growth rotation, while the patient on the right has a posterior growth rotation. Then we have to evaluate the smile static, and the most important one is the incisal show on smiling. That's very important because that decides if we're going to change the vertical position of the maxilla. We are doing orthognathic surgery. We want to position the upper incisor in the most aesthetic position. So now we assess the position of the incisors anterior-posteriorly through assessment of the jaws, and now we assess the vertical position of the incisors. So as you can see here, in both cases, the incisors show as smiling is the full clinical crown, which is very good, which means that we will not change the vertical position of the incisors. Then we do assessment of the TMJ. Usually these patients have a huge malocclusion. We know from the evidence that there is no strong connection between malocclusion and TMD. However, we still have to do a full assessment for the TMJ to make sure that we don't have any TMD before we send the patient to the orthodontic surgery. Then we do the intraoral assessment, which is very similar to the regular intraoral assessment that we do. We check the teeth present, crowding, spacing, molar relationship, canine relationship, incisor relationship, etc. We do a full assessment. As we can see here for the girl, this is the intraoral photograph. She has a mild crowding in the upper and lower arch. She has a class 3 incisor relationship. She has a bilateral posterior crossbite without displacement, while the guy has a class 2 division 2 malocclusion. As you can see, the molar relationship is even class 2 plus, it's even more than class 2. He has a huge or severe discrepancy between upper and lower arches. Now, after we finished the assessment, we move to the second stage, which is planning. So we want to know what we're going to do. Now, we don't usually treat patients to numbers, so I don't go for a lateral cleft tracing and then I say, okay, the SNA is, for example, the normal value is 81 and he has a value of 75. That means I have to move the maxilla 5 degrees forward. This is not how we do it. The way to do it is to start from the extraoral assessment. So we look at the patient and say, okay, if we want to improve the profile, what are we going to do? So from the assessment that we did, we know that he has a class 2 due to retrognathic mandible. So what we have to do is to move the mandible forward. Now, how many millimeters do we have to move the mandible forward? So if you look at his profile, you can see that, okay, well, we need to move the mandible forward at least 8 millimeters. That will give him a straight profile. And we said that in the maxilla, it's slightly weak maxilla or the nasolabial angle, and we need to support that. However, he has a class 2 division 2 malocclusion and the incisors are retroclined. So if we procline the incisors, we can give him the support in the upper, and in the lower arch we have to move the mandible forward. Now moving the mandible forward 8 millimeters, that means that we have to end up with an overjet of 10 millimeters. How is that? Overjet of 10 millimeters before the surgery. And now the surgeon will move the mandible 8 millimeters forward and the 2 millimeters are remaining as an overjet. So that's how we plan this patient. And we don't want to change the maxilla vertically or anteroposteriorly. Because on smiling, he does not show gummy smile or has a reduced incisal show on smiling. So if you look at this patient as well, if you can see in the frontal profile, she has an asymmetry. She has increased lower facial height, and she has a weak maxilla, and the mandible is protruded forward. So what we need to do is to set the mandible backward. We have to move the maxilla forward. We have to impact the maxilla posteriorly to allow auto-rotation of the mandible to reduce the amount of the lower facial height, and we want to correct the asymmetry that is present. So it's pretty much a lot of movement that we have to do. So if we decided now, okay, anteroposteriorly, let's start with that. We have to move the maxilla forward. We have to move the mandible posteriorly. So that means that I want to move the mandible at least 5 millimeters posteriorly, and the maxilla to move forward by at least 4 millimeters to give her the support. So this movement is 9 millimeters of movement. So what we're going to do is to finish with an overjet of -7. How is that? Because when we do a -7 millimeter, now the surgeon will use an extra 2 millimeter for overjet. So that's give us the 9 millimeter movement that we want. So this patient is now planned for a -7 millimeter of overjet. Now vertically, we don't want to change the vertical position of the maxilla anteriorly, simply because the patient incisal show a trace on smiling is normal. But we want to reduce the amount of the lower facial third. So what we can do is to do an impaction of the maxilla posteriorly only. So we will not impact the whole maxilla. We will only impact the maxilla posteriorly, allowing the auto-rotation of the mandible to reduce the amount of lower facial third. Now we have, before going through the planning even more, now we have to know the common surgical procedure that we do, or our surgeon colleagues does. The first one is the maxilla. We call it the Herford 1 osteotomy. In this osteotomy, they go before just above the ABCs of the upper incisors and upper maxillary teeth, and they move the maxilla forward. And then, as you can see, this is what we call it rigid fixation. They use plates to splint the maxilla. The second technique in the mandible is called bisagittal split osteotomy. And this procedure is done in the mandible, in which they slide the mandible, as you can see, forward. And even though they can do it posteriorly as well, they can take a block of the mandible and remove the mandible posteriorly. I'm sure that our colleagues in the surgery department explained this for you. The third type of orthognathic surgical procedure is segmental osteotomy. So if you can see here for this patient, she has an anterior open bite. So one way to correct this anterior open bite is to do an impaction on the posterior part of the maxilla. So usually we create space for the surgical cuts. Here in this video they extracted the premolar. So the surgeon now, what he does a segmental osteotomy in which he impacted the posterior part of the maxilla and retract the upper part of the maxilla. So the patient now will have an auto-rotation of the mandible and the overjet is reduced. So we can do this osteotomy in which we have to impact the maxilla only, or we can set the anterior part of the maxilla. So it's called a segmental osteotomy. So what is the sequence of the treatment? We start with the history and examination, we do planning, we do pre-surgical orthodontics, then we send the patient for surgery, and then post-surgical orthodontics, and the patient is done. So now we have so far talked about history and examination, we talked about planning, and now pre-surgical orthodontics. So what is the aim of the pre-surgical orthodontics? It's a treatment that is done before surgery to allow the correct of the anterior, posterior, and vertical position of the incisors. And this is allow the surgical move to take place. So let's go and dig deeper into the pre-surgical orthodontics. So what we do, first we do what we call it decompensation, then alignment and leveling, arch coordination, then create, in some cases, enough space for osteotomy cuts if segmented surgery is required. So we'll start by decompensation. What do we mean by that? So if you see this patient here, she has a class 3 malocclusion. And as we know, for a class 3 malocclusion patient, we do the tissue will compensate for the class 3, the soft tissue. So the upper incisor will be proclined and the lower incisor will be retroclined in order to compensate for the class 3 skeletal discrepancy. So if you can see here, for example, in the upper incisors, the angulation, the lateral cleft tracing is 120, the normal is 109. So the incisors are proclined. While the lower arch, the lower incisors are retroclined, they are 79, while the normal is 92. So this happened because the teeth are trying to compensate the skeletal discrepancy. Now if you measure this overjet here, it's only minus maybe 4 millimeter. And as we said before, when we plan this patient for the surgical movement that we want to do, we want to move the maxilla and the mandible 9 millimeter, which means that the target overjet for us is minus 7 millimeter. So we are short of minus 3 millimeter. So what we do here, we do decompensation. So we procline the lower incisors to go back to the original position, and we retrocline the upper incisors until we get minus 7 millimeter of overjet. So basically, the patient will look worse before the surgery. So if you can see here, this is the patient before we start the treatment, and this is the patient before she went to the surgery. So if you can see that there is a huge minus overjet here after the treatment. So all of that was done because we retroclined the upper incisors and we proclined the lower incisors. This is what we call it decompensation. So basically, we remove the dentoalveolar compensation that took place. However, how much do we have to remove this dentoalveolar compensation? It depends on how much tooth movement do we need. So here in this case, for example, we want minus 7 millimeter of overjet to give us a 9 millimeter of movement. And that's why we procline the lower incisors, retrocline the upper incisors until we got these numbers, until we got minus 7 millimeter of overjet. So as you can see, this is the patient just before she went to surgery. So you can see the amount of the proclination we did for the lower incisors. So the lip became everted in the lower arch. The upper lip now is weak because there's a support. So the profile look much worse than when we started. And this is something that you have to tell your patient before we start orthognathic surgery. The other patient has a class 2 division 2. As you can see that the upper incisors to the maxillary plane are 95. They are hugely retroclined. And the lower incisors to the mandibular plane are 99, while the normal are 92. So they are proclined because they are trying to compensate for a class 2 skeletal. So what we're going to do now, we said that we want an overjet of 10 millimeter. So what we have to do is to procline the upper incisors. And this gives us as well the support that we want for the upper lip because we're going to procline the upper incisors a lot. And in the lower incisor, we have to retrocline them until we get an overjet of 10 millimeter. So here we started with retroclined upper incisors, and here on the right, after the proclination and the overjet is 10 millimeter. So now we've finished decompensation, and we move to the second stage, which is alignment and leveling. So what do we mean by alignment and leveling? Alignment, it means that to relieve crowding. So if we have crowding, we have to to align the teeth, make them straight. So if you can see the lateral incisors is fluid, the teeth are crowded. Now on the top photograph, now the teeth are well aligned. So what do you mean by leveling? Leveling is to make the teeth, all of them at one level. So that's what makes the surgical movement easier because when you slide a flat surface on a flat surface, that would be much easier than sliding not a flat surface, obviously. So here the incisors and canines and the laterals are not on the same level, so everything now on the same level as you can see in the top photograph. Now this is not the case in every case that we have to level the arch. Now if we do an segmental osteotomy, we don't have to level the arch. So if you can see this patient here, he has a reduced slightly incisor show on smiling, and he has an anterior open bite. So what we want to do now, because when he smiles, he doesn't show the full clinical crown, we decided to go and do an orthognathic surgery in which we do a segmental osteotomy and we drop only the anterior from canine to canine. We drop them forward, and he has a class 3 as well, so we're going to drop them downward and forward to improve the incisor show on smiling and at the same time to achieve better class 1 incisors. So in this case, as you can see, we have different levels. So you can see the blue line, they represent the posterior teeth, and they are on one level on the molars and premolars, while the incisors and the canines are in a different level. So if I use a continuous arch wire, what's going to happen is that the upper incisor will be extruded, and we will have a leveled arch. The problem with the extruded incisor is that this movement is not stable. So once I remove the wire, all what's going to happen is intrusion of these incisors, and I will end up with a relapse, and the orthodontic treatment will be done for nothing. So what we want to do now is not to extrude these incisors when we have the arch wire. So what we did is we introduced a bend in the arch wire. We did not level the arches. As you can see here, we have a bend in the wire, so now we have two levels of the occlusion. And now we maintain this difference in the two levels of the occlusion. And as you can see here, the patient has a class 3 because we rolled one to advance the maxilla forward and the premaxilla and drop it down. This is what we call a segmental osteotomy. And as you can see, we have a push coil here, and the reason for the push coil between the canine and the premolar is to create enough space for the surgical cuts to be done. This is the patient after we finish the treatment. You can see now everything is in one level. What we did is that we moved the maxilla forward and dropped it down. The third pre-surgical orthodontics is to do what we call it arch coordination. We use this figure a lot. The black color represents the maxilla, the pink color represents the mandible. And as you can see, the change in the anterior-posterior dimension of the maxilla affects the transverse one. For instance, that in the top we don't have any crossbite, but if we move the mandible forward, we will have a crossbite, because simply the wider part of the mandible now will include the narrower part of the maxilla, and as a result we will have a crossbite. So sometimes fixing or correcting the crossbite happens by only changing the anterior-posterior position of the maxilla and the mandible. So for this patient, for example, if you can see that he does not have any crossbite before treatment, so what we do for him, we take an impression and we move the mandible on hand articulation. We look at the overjet of 2 millimeters and we see if we have a crossbite or not. If we have a crossbite, then we have to do expansion pre-surgically, so that when the patient or when the surgeon does the advancement of the mandible, we will not have any crossbite. However, if you can see this patient, she has a class 3 and as well the posterior crossbite. So if we decided to correct this one pre-surgically, that would be slightly wrong. So what we want to do is to postpone it until we finish the surgery. And why is that? Because we will move the maxilla forward and the mandible posteriorly. That means that we will restore the correct relationship between the maxilla and the mandible. So now the wider part of the maxilla will bite and occlude with the wider part of the mandible. So we might not need to do an expansion. The crossbite will be corrected by itself. However, to make sure of that, we take an impression again, we articulate them, hand articulation with a positive overjet, and we will see if the overjet is of the crossbite is corrected or not. After that, we do the creation for space of the surgical osteotomy. As we said, this patient, we want him to go for osteotomy, segmental osteotomy. The surgical cuts will go between the 3 and the 4, so we have to create enough space for the surgeon to do the cuts for him. So as you can see here that we created space for the surgeon just to go and insert the blades. So now, once we have done with the preparation of the patient, now we are ready to go for surgery. So we do something we call the preparation for the surgery. Now the patient is ready to go for the surgery, but how the surgeon will know exactly how to move the jaws and what are the amount of the tooth movement. What we do something we call it model surgery. So basically, you take an impression, you mount them in an articulator, you use a semi-adjustable articulator, you use a Facebook, and you articulate the maxilla and the mandible. I'm sure you know and understand that from prosthodontics. So now this is a mounted articulator, and as you can see, they drew a vertical lines and a horizontal line. So why is that? Because when they do a surgical movement, they measure the distance between these lines, and that's indicate the amount of the movement that we do. So we operate on the patients. For example, in this here, the maxilla has to move forward. So what they do is they cut the maxilla from the just above the base, and now the maxilla is moved forward. Now the distance between the red lines, as you can see it here obviously, is the amount of the movement that we did in anterior posterior direction. If you want to move it vertically as well, you can do that, and you measure the distance between the two vertical lines, and as horizontal lines, sorry. So you can see here we have two horizontal lines, and the distance between them in the left is more than that on the right. That means that the maxilla is impacted. So this is how the mock surgery has been done. So what you do is you do the maxilla first, and then you place and you produce a guiding wafer, and I'll show you a slide next how this wafer look like. And we call this an intermediate wafer. And then after you do the intermediate wafer, you keep it aside, then you move the mandible, and then you do the final wafer. This is the wafer. Basically, it has the teeth indentation of the upper and the teeth indentation of the lower, and the surgeon uses it inside the patient's mouth. So what happened now? The patient is in the surgery. They start usually with the maxilla, so they break down the maxilla and do the fourth one osteotomy. So now the maxilla is completely mobile. So you need to know where are you going to move the maxilla forward. So what you do is they place the wafer on the mandible. So the mandible now will be the reference for the maxilla, and then they ligate the mandible and the maxilla together. So that's mean now the maxilla moved into right place. Then they use plates to, as you can see in the photograph, now this is the final position of the maxilla to fix the maxilla. Now the maxilla is in the right place, then you finish with the intermediate wafer that we produced in the lab, and then the surgeon will do the surgery on the mandible and will use the final wafer to place the mandible in its final position. As you can see, we place usually, before we send the patient to surgery, hooks on the wire. So these hooks can be used by the surgeon during the surgery to ligate the teeth together and to the wafer. So now the patient is finished with the surgery. So what we're going to do post-surgically, we usually give the patient guiding elastics. We're going to complete any movement that's not undertaken pre-surgically. If we do a segmental osteotomy, we usually kick the roots away from each other. So after the surgery, what we do, we bring them back to their normal position, and we do detailing and settling of the occlusion, and we finally correct any minor discrepancies resulted after the surgery. So what are the guiding elastics? So the patient now has a normal occlusion, as you can see, everything is perfect. But now the proprioceptive of the muscles are not working. The patient doesn't know how to go and close his teeth. He doesn't know because the muscles are kind of teared during the surgery. So he needs the help, and the help we will get it from the guiding elastics. So we give the patient this elastics that help him to bite into the centric relation. To complete any movement that is not done pre-surgically, for example, the expansion. So for this patient, for instance, now correcting the crossbite would be very difficult pre-surgically. And as we said before, changing the anteroposterior position of the maxilla into relation to the mandible, that's mean if we move the maxilla forward, that we are bringing the wider part of the maxilla to bite and occlude to the wider part of the mandible. So the crossbite might be corrected fully for this patient after the surgery, or we might need to do a little bit of expansion after the surgery if this anteroposterior movement did not correct the crossbite fully. So we decided to postpone this to be post-surgical. So anything that is not being done pre-surgically, we can do it post-surgically. We do root paralleling at the segmental osteotomy side. Again, this patient here, the canine and the fore are tipped, both of them. When the canine root is tipped this mesially, the root of the fore is kicked distally to protect the roots actually from the wear of the surgeon during the surgery. And now we have to bring them back where they are, and we want to close the residual spaces, as you can see here. Then we can do what we call it detailing and settling of the occlusion. So here the patient is gone for orthognathic surgery. As you can see, there's a huge amount of posterior open bite or lateral open bite. So simply we ask the patient to wear settling elastics, and this is going to bring the teeth together into occlusion, as you can see here. Last thing to be done post-surgically is to correct minor discrepancies resulted after the surgery. So if anything went wrong in the surgery or the planning was done but it was not done 100%, sometimes we get incomplete results from the surgery, or sometimes it just things happen. And this patient is an example in which everything in the planning was done correctly, the surgery was done amazing, but the results was not good. So what's happened? So let's see this patient. She, if you look at her and the profile, she has a huge class 2 skeletal. She has a retrognatic mandible. If we dig deeper, we ask her to bring her photograph from the past and see if she had any history of trauma. So if the photo on the left side, that's her during the as a teenager, and on the right side when she graduated from university. So if you can see, she has a proper chin when she graduated from university. So when she was in university, she did an orthognathic surgery in which they moved the mandible forward, and she was happy for a couple of years. But then she relapsed. And after taking a cone beam CT scan, we noticed that she had a small condyle. So maybe there was previously a resorption in the condyle of the mandible. So resorption in the condyle of the mandible means that the mandible will go downward and backward. Thus make her have an anterior open bite, and she will have a class 2 skeletal. So the patient was told that if she gonna go for orthognathic surgery again, she might have again the idiopathic condylar resorption, and the results will relapse. However, the patient is not happy with the way she looks, and she wants to take the risk and do the surgery. So she went to the surgery, and this is how she came out after the surgery. She has an anterior open bite. This is after the surgery. And the reason for that, because she has an idiopathic condylar resorption again. So what happened is the mandible is dropped downward and backwards slightly. That was very minimal. She was lucky. And the profile was fine, but she has an anterior open bite. So the patient had 2 surgeries so far. I can't send her again for surgery. What we did for her then is that we inserted mini screws and we tried to intrude the posterior teeth. And that's how it's done. We intruded the posterior part of the maxillary teeth, and that's resulted in auto-rotation of the mandible, which will help to improve the class 2 skeletal as well, and the overbite is corrected. So how she looks like after the surgery, and this is her before the surgery. Huge improvement in the profile of the patient. I know she still looks slightly class 2, but she's much better than when we started. Sometimes a patient can go for orthodontic surgery without the need for orthodontic treatment. These are kind of not rare cases, but they're present, but you need to be very selective. Now, as we said, we do usually an orthodontic treatment before and an orthodontic treatment after. Now, there are certain cases in which they don't need orthodontic treatment at all. So if you look at this patient here, she has an increased incisal show at rest, that she's showing at rest the full clinical crown. And during smiling, she's showing maybe 10 millimeter of the gingiva. So the treatment plan for her was only maxillary impaction. So what we did for her, we did a proper planning mock, and we did an impaction of the maxilla. And you can see here that she has a reduced now incisal show in smiling, and during smiling, sorry, if you can see here, that's her after the surgery. On the right side, she's on smiling now, showing the full clinical crown only without the gingiva. And during rest, she's only showing 2 to 3 millimeter of the incisor, which is normal, instead of showing the full clinical crown. So the patient is happy. So what we did not do orthodontic treatment, it's just only surgery. And these are the bondable bars that we stick to the teeth to use the settling elastics, because we have to use the settling elastics. This photo is for different patients just to see what we mean by the bondable bars. So sometimes, yeah, patients go for orthodontic surgery without the need for orthodontic treatment. Now, recently, there is some publication about talking about sending the patient first for surgery. Well, my personal opinion about the surgery first, it's a great option, but we have to be very selective with the cases that is appropriate for surgery first. Let's see what happened with those patients. This is our patient that she has increased lower facial height, she has asymmetry, she has a weak maxilla, retrognathing maxilla, proctognathing mandible, and this is before surgery, and this is her after the surgery. So we corrected the increased lower facial height, corrected the asymmetry. They did for her something we call it lip evergence, so they gave her a little bit of upper lips, and the profile of the patients improved hugely. Impaction of the maxilla resulted in auto-rotation of the mandible with a reduction in the lower facial third, and anteroposteriorly now she has straight profile. And this patient here was treated with advancement of the mandible, if you remember. So when smiling, we broke line upper incisors, and this is him after the surgery. You can see the mandible is advanced. Now this is him 1 year after the surgery. So orthodontic and orthognathic surgery give the patient a huge result, a huge advancement and improvement in the profile. However, we should be very careful when we do that. We have to assess the patient fully and assess the patient with his profile and the way he looks, the status of the patient, I mean his body. So, for example, this patient, um, she's slightly short and she has a retrographic mandible. When she went for surgery, we did her surgery and we advanced the maxillary mandible for her. She's happy with the profile after we finished the surgery. But for me, I was not really happy because I don't think that her kind of, I don't want to say her head, but like her face does not fit her body. She has a now straight profile, strong chin that doesn't match with her body. So planning orthodontic surgery, it's not only about assessment of the face. You have to assess the whole patient, the whole body, if this is movement can improve the patient profile or not. Luckily, this patient was happy, so we were fine. The last part of our lecture today is talking about the three-dimensional prediction and planning. So for example, this patient, you can see from the profile, he looked fine. But if you look at the front one, he has a huge asymmetry. The mandible is deviated to the right side. If you assess him from a bird view, you can see the mandible is completely deviated to the right side. Now, correcting an asymmetry is something that you need to plan with a 3D because you need to guarantee exact movement of the chin to give you the profile of the patient improved. So what we do in a 3D-dimensional planning, you take a CBCT of the whole face. So that's giving you 3D representation of the skull of the patient. So this is the mandible, this is the maxilla, and you can see that the mandible is shifted to one side. As you can see, this is the patient and this is his cone beam CT scan. The CT scan will give you a soft tissue as well. So this is the soft tissue, but this is not realistic for soft tissue for him. So what we can do, we do something we call a stereophotometry, which is basically we take a 4D photograph of the patient, 4-dimensional imaging. This is the one we used in Glasgow for a while. So I'm sure now that there's a more advanced one, but this is a 4D camera. So the patient was taken in a 4D, and then we do superimposition of the 4D photograph that we took, and we superimpose it on the soft tissue that we got from the cone beam CT scan. So now we have the patient face and bone, skeletal one, the bone, and the soft tissue on the screen. So what we do the surgical move on the screen. So now we corrected the maxilla and the mandible on using huge softwares. There's a couple of softwares that are really expensive that we can do this surgical moves on them. And then the soft tissue will follow. So we know exactly the amount of the surgical movement that we want to do. This is one example of a soft tissue orthodontic patient surgery software. It's called Maxillum. That's the one we use in Glasgow. As you can see, you can move the jaw and then the chin will follow, so you know exactly what is the amount of the surgical movement and in which direction that you're going to do. It's very nice, fancy tool, but it does have its limitation. The limitation is now when you move the maxilla forward 5 millimeter, we don't know exactly the response of the soft tissue. So it's not a 1-to-1 ratio. So moving the maxilla forward 5 millimeter does not mean that the soft tissue A point will move 5 millimeter forward because there is stretching of the soft tissue. And that's different from one patient to another. So if I go for do orthodontic surgery for 3 patients, moving the maxilla forward by 5 millimeter, one of them, the maxilla will move 4 millimeter, the other one 3 millimeter, the other one 3.5 millimeter. So they will have a different response of the soft tissue. So using this software give you always the same answer, and it will not consider the difference between the patients. So using this software is good, but we have to be careful when we use it and understand this fact. So now instead of doing the mock planning as we did in the previous patients, simply we do the surgical moves on the on the screen, and then on the top, as you can see, we produce what we call it the virtual wafer, and after that we print the virtual wafer using a 3D printer. I was lucky in Glasgow that was the my doctorate research program, in which I evaluated the accuracy of this 3D printed wafer, and it was as accurate as the conventional wafer. So here's the patient before, here his planning, and his after the surgical treatment. That's it all for everything. Thank you for listening.